Okay, good afternoon, everyone. Thanks for spending your Saturday afternoon with us. So I'm Lin Weiqian. I'm a heart failure cardiologist from the National University Heart Centre, Singapore. This is the second episode of the series of amyloidosis lectures. And this series has been sponsored by Pfizer and organized by the Singapore Cardiac Society. Today, the theme of this webinar would be multidisciplinary management of amyloidosis. As we know, amyloidosis is a multi-systemic disease, and there are many considerations for patients with amyloidosis other than just heart failure, cardiomyopathy. So we are going to have a panel of experts to let us know about the other manifestations of amyloidosis, which are equally, if not even more important in the management of this disease. So as I mentioned, this will be a multidisciplinary panel with a hematologist, a neurologist, and an electrophysiologist on board today. Some housekeeping before we start. For Singapore registered healthcare workers, please stay throughout the whole duration of this webinar for us to submit your CPE, CME points. And at the end, to get a certificate of attendance, please complete the survey by scanning the QR code at the very last slide. Q&A session will be at the end of the whole webinar. So use this Q&A button at the bottom of the screen to type in your questions, and we will try to answer all questions either through the chat or answering it live. So the topics that we'll cover today would include light chain amyloidosis. What are the latest developments in this field? Neurological manifestations in transthyretin cardiac amyloidosis, as well as the electrophysiological problems that we face in managing this group of patients. So let's skip this. So our first speaker is Dr. Sanjay Demel. He is a senior consultant at the Division of Hematology, Department of Hem-Onco at the National University Cancer Institute, Singapore, NCIS. He is a close collaborator of mine. His subspecialty interests include myeloma and of course light chain amyloidosis. And all my patients with any suggestion of light chain amyloidosis will invariably see Dr. Sanjay. So he is not available today to give a live lecture, but he has kindly recorded his lecture and we will play back his lecture today. At the beginning, it might be a little soft, so I'll need everyone to tune up your volumes. So Dr. Sanjay.
Good afternoon. I'm Dr. Sanjay Demel. I'm a hematologist based at NCIS. My apologies that I can't join you in person today. I'm most grateful to Wei Chin for his kind invitation to speak at this webinar. What I hope to do today is to give you an overview of light chain amyloidosis, starting with the pathophysiology, clinical presentation and diagnostics, and then moving on to staging and management. As you know, amyloidosis comprises many different subtypes, and as hematologists, the subtype that we focus on is immunoglobulin light chain amyloidosis. Because this typically arises from clonal plasma cell or B cell dyscrasias. The plasma cell clone produces abnormal free light chains, which subsequently misfold to form prefibrillar aggregates, which then go on to form amyloid fibrils, which deposit in organs and cause the various clinical manifestations that we know of. Interestingly, the prefibrillar aggregates themselves can cause direct tissue toxicity, especially to the heart. Once the process of amyloid fibril formation commences, it progresses rapidly, even though the precursor immunoglobulin is only present at a lower concentration. And this may at least partly explain why patients with light chain amyloidosis experience a rapid clinical progression. And here we can see how the amyloid fibrils disrupt the tissue architecture in the heart. And interestingly, the serum free light chains themselves, even before they become amyloid, can cause direct cardiac toxicity and induce apoptosis of the cardiac myocytes. It's also been shown that certain mutations in the variable regions of the immunoglobulins can target the amyloid to specific organs, for example, cardiac or renal, as shown here. The presentation of amyloidosis can be quite non-specific because it can involve a variety of different organs. So a high index of clinical suspicion is required to even consider this diagnosis. And it's apt that we are discussing this in a cardiology webinar because cardiac involvement is one of the most common and important manifestations of light chain amyloidosis, with heart failure being one of the common presenting symptoms. We can't forget the other organs that can be involved, such as renal involvement, where nephrotic syndrome is common, soft tissue amyloidosis, neurologic manifestations, as well as GI amyloidosis, which can present with diarrhea and so on. The diagnosis of amyloidosis requires histopathology, and this is typically based on Congo red positive staining, and under polarized light it shows this apple green birefringent appearance. One of the challenges that we face in the diagnosis of amyloidosis is from which site to obtain the tissue, and the sites that are listed here are options for us to biopsy to get the diagnosis. However, it's possible that the biopsy of some of these sites may not yield the diagnosis, in which case we have to consider biopsying the involved organ, which may give us the highest yield for diagnosis but may also be associated with more risks. So once we have established the diagnosis of amyloidosis, we then need to confirm the subtype of the amyloid fibril. And immunohistochemistry may often not be adequate for this purpose. Hence, mass spectrometry is currently recommended as the standard of care for amyloid fibril subtyping, and because it has an excellent sensitivity and specificity for subtyping of amyloid fibrils. Once we have confirmed light chain amyloidosis based on mass spectrometry, we then need to confirm what type of plasma cell or B cell clone is driving this, and I will go into a bit more detail on that next. We also need to assess the extent of organ involvement and stage the extent of disease. So in the diagnostic workup of the plasma cell or B cell clone that's driving amyloidosis, we have a few key differential diagnoses to consider. MGUS and smoldering myeloma are precursor states of multiple myeloma, and any of these plasma cell dyscrasias can drive amyloidosis. And we also can't forget that small B-cell lymphomas, although rare, can also be the driver of light chain amyloidosis. So we start off with a basic clinical assessment, some basic blood investigations, and we also perform imaging using a CT skeletal survey to exclude bone lesions. And we are specifically interested in ruling out combination of clinical features which can be recalled using the acronym CRAB, hypercalcemia, renal impairment, anemia, and bone lesions, which are the typical clinical manifestations of multiple myeloma. So we next go on to characterize the paraprotein, and this is achieved through three key diagnostic tests: serum electrophoresis, serum immunofixation, and the serum-free light chain assay. And through this panel of tests, we can identify the majority of paraproteins that underlie light chain amyloidosis. we can also quantify the paraprotein using densitometric analysis of the electrophoretic band, and we can also perform quantification of individual immunoglobulins using nephelometry. So once we have characterized and quantified the paraprotein, we then go on to do the bone marrow studies, which is the definitive way to identify exactly what plasma cell or B cell clone is underlying the amyloid. So in the bone marrow, we start off with the morphologic assessment, and in this case we can see the bone marrow is full of these abnormal cells. These are plasma cells. And in the bone marrow, we can also perform flow cytometry, which confirms the clonality of plasma cells, and this can also be achieved through immunohistochemistry on the trephine biopsy. Genomic assessment is crucial in the diagnosis of many hematologic malignancies, including the plasma cell dyscrasias, and this is achieved through conventional karyotyping as well as FISH. And this is an example of a genomic abnormality which is characteristic of light chain amyloidosis, and I will come to talk a bit more about this later on. So once we have established the underlying plasma cell or B cell clone, we then go on to perform staging. Several staging systems have been proposed for light chain amyloidosis. However, the staging system that we use, and that's probably used most commonly worldwide, is the revised Mayo staging system, and this requires three components: the troponin, BNP, and the differential of the involved over uninvolved free light chains. And that is established using the serum free light chain assay, which I described earlier. So if a patient has only one of these, has none of these points, they are stage 1. If they have 1 point, they are stage 2, 2 points, they are stage 3, and so on. And the Mayo staging system gives us a fairly clear delineation between the different prognostic subsets, with cardiac stage 4 patients having the worst outcomes. And this also highlights the two key determinants of survival in light chain amyloidosis: the plasma cell burden as determined by the free light chain differential, and cardiac involvement as defined by the troponin and BNP. So in addition to those clinical staging parameters, the genomics has also been shown to play an important role, and the translocation that I showed you on the karyotyping picture earlier is this one, the translocation 1114, which leads to the upregulation of cyclin D1. And this occurs in about 50% of patients with light chain amyloidosis and is typically associated with an inferior outcome. So the management of light chain amyloidosis can be divided into the supportive care and the definitive therapy. And the supportive care is a critical part of the treatment for these patients, and this is delivered by a multidisciplinary team, given that this disease can involve so many different organs. And we also shouldn't forget the importance of high quality nursing, intensive care, and of course prompt management of infection and meticulous management of fluid balance. When we talk about the definitive treatment for light chain amyloidosis, the current paradigm is plasma cell directed therapy, and the majority of treatments for light chain amyloidosis are therefore borrowed from multiple myeloma, which is a much more common plasma cell dyscrasia. The idea here is that if we remove the underlying clone, or at least eradicate it as far as possible, we are shutting off the supply of the light chains and thereby reducing the formation of new amyloid fibrils. And what we are trying to achieve with these treatments is firstly a hematologic response, which means a reduction in the paraprotein to as low a level as possible, ideally to a point where it cannot be detected. And that's defined by as a complete response. And what we want to see following on from that is an organ response. And the organ response is defined based on the organ that is involved. So for example, for the kidney, it's based on the improvement in proteinuria. For the heart, it's a reduction in the BNP. And we can also combine the hematologic and organ response into this CHOR model. So this is an overview of the treatments that have been used for light chain amyloidosis over the years. And there's one treatment that I would like to highlight here, which is autologous stem cell transplant. So autologous stem cell transplant is a standard treatment for multiple myeloma and has also been adopted in AL amyloidosis. However, it's quite clear that light chain amyloidosis and multiple myeloma are not the same disease. And in fact, patients with light chain amyloidosis who undergo transplant do suffer higher morbidity and mortality. And the morbidity and mortality associated with transplant has led to the questioning of whether transplant still has a role in the treatment of cardiac amyloidosis. And that is particularly important now in the era of potent plasma cell-directed therapies such as daratumumab. Daratumumab is a monoclonal antibody which targets CD38, which is strongly expressed on plasma cells. And it induces direct plasma cell toxicity as well as through the engagement of a variety of immune effector cells. And the role of daratumumab in the management of light chain amyloidosis was established by the Andromeda trial, which used daratumumab in combination with the previous standard of care, which was bortezomib, cyclophosphamide, dexamethasone, in comparison to VCD alone. And the primary endpoint of this trial was a complete hematologic response, which was easily achieved. But probably what was more clinically relevant for the patients is the extent of organ responses that were seen in the daratumumab arm. And these results led to Dara-VCD being adopted as the new standard of care for light chain amyloidosis. So the current treatment algorithms for light chain amyloidosis, even in patients who are eligible for a stem cell transplant, if they achieve a good response to Dara-VCD, we have the option of deferring the transplant and just going with the Andromeda protocol by itself. And of course, the role of stem cell collection in these patients remains a question given the potential morbidity and mortality that it can cause. And this is an individualized decision that we make on a case-by-case basis. And of course, for patients who are not eligible for transplant, they would go exactly according to the Andromeda protocol, which I showed earlier. So we have made great progress in the treatment of light chain amyloidosis, particularly in the field of plasma cell-directed therapies. However, there remains an important unmet need in that the plasma cell-directed therapies do not really affect the amyloid fibrils that are already deposited in the organs. And this important treatment gap has led to the development of the fibril-directed antibodies, and I will describe some of the data that's emerging from these. Anselamimab is an antibody which binds to light chain amyloid fibrils and targets them for phagocytosis. And preclinical data showed that this antibody can indeed dissolve amyloidomas when in this murine model. And they went on to test this in phase 1 clinical trial of patients with cardiac amyloidosis who had not responded to their prior treatment. And more than half of the patients that they enrolled achieved a cardiac response. And based on those data, there are currently 2 phase 3 RCTs using anselamimab plus VCD compared to placebo plus VCD. And it will be interesting to see the results of these when they read out. Bertamimab is also a fibril-directed antibody which binds to serum amyloid protein and also cross-reacts with the light chain amyloid fibrils. And similar to anselamimab, it also targets the amyloid fibril for phagocytosis. Bertamimab was studied in the phase 3 VITAL trial, which compared bertamimab with standard of care treatment versus placebo plus standard of care in patients with cardiac amyloidosis. When they looked at all comers, all the patients in the trial, they did not see a benefit for bertamimab, but they went on to do a post hoc analysis of just the cardiac stage 4 patients where they saw a signal for a benefit with bertamimab. And they have therefore gone on to design the AFFIRM-AL trial, which is specifically for cardiac stage 4 patients, and it compares bertamimab plus dara-VCD or VCD with the standard treatment without bertamimab. So this trial is ongoing. In addition to the fibril-directed therapies, there are also novel plasma cell-directed therapies which are coming up against amyloidosis. Venetoclax is a BCL2 inhibitor which is specifically potent against plasma cells with the 11-14 translocation. And this has shown promising responses in AL amyloidosis. Belantamab and teclistamab are both newer types of immunotherapy which target BCMA on plasma cells. Very small case series, some suggestions of response, but very early days for these drugs. So we've come a long way in the treatment of light chain amyloidosis. There's been an explosion of new, highly effective agents with very acceptable toxicity profiles in the last decade. However, despite all these improvements, and even if we have a high index of clinical suspicion, most patients with cardiac amyloidosis are often diagnosed with advanced disease. And for many of them, it may even be too late for the treatment to have a significant effect on their life. So the diagnostic process which I described earlier can be quite time consuming, and that takes away precious time which could be used to initiate treatment. So if it's possible to have a rapid blood-based diagnostic to quickly confirm the diagnosis of light chain amyloidosis, that would make a big difference in the treatment of these patients by expediting the diagnostic process. We also don't have a widely available imaging modality to establish the extent of organ involvement. And lastly, screening of patients who are on follow-up for MGUS with amyloid-related symptoms is also very important. So these are some of my thoughts on the future of clinical trials in light chain amyloidosis, the combination of a fibril-directed antibody with a CD38 monoclonal antibody with venetoclax for patients with the 11-14 translocation may provide a chemo-free combination with low risk of neuropathy and potentially be a highly effective combination for light chain amyloidosis. However, to study these novel combinations, we need large international collaborative trials like Andromeda, and it's very important that we collaborate to achieve this, because that's our best chance of improving the outcomes for our patients. Thank you very much for your attention. Once again, I apologize I can't join you in person, but I'm happy to take questions by email. Thank you.
Okay, thank you, Dr. Sanjay. So I see a question in the Q&A box, whether this webinar will be recorded and be on demand access. Yes, this is currently being recorded and it will be hosted on the Singapore Cardiac Society website. So just keep an eye on the website, visit it periodically. We will upload it as soon as feasible for us. Okay, let's move on. Our second speaker is Dr. Kay Ng. She is a neurologist at the National University Hospital. She's a close collaborator of mine. All my transthyretin amyloidosis patients will invariably go through her clinic doors. Her subspecialty would be neurophysiology as well as neuromuscular diseases. So Dr. Kay Ng will share with us the neurological manifestations of cardiac amyloidosis. Kay, please.
So thanks, Wei Chin. I want to thank Dr. Lin Wei Chin and the Singapore Cardiac Society for inviting me to speak today. I'm just going to share my slides. Okay, so I think everybody can see my slides. So as Dr. Lin mentioned, I'll be talking about neurological manifestations in amyloidosis. Primarily, the question we'll be asking, since this is an audience of cardiologists and nurses, what neurologic involvement can you expect when a patient has cardiac amyloidosis? So amyloidosis can be classified as hereditary or acquired, and of these many causes, transthyretin is the most common inherited variant worldwide, while AL amyloidosis, as mentioned by Dr. Sanjay, is the most common form of systemic amyloidosis that affects the neuromuscular system. I'll therefore be focusing more on these two amyloidoses in my talk today. So in the outline of my talk, I'll be talking about the pathophysiology of amyloid neuropathy, what are some of the neurologic clinical features of amyloidosis, some red flag signs and symptoms that may aid us in our diagnosis, and briefly touch on the diagnostic algorithm for patients with neuropathy and a clinical suspicion of amyloidosis. So first, transthyretin amyloidosis is an estimated global prevalence of about 10,000, but we can expect a diagnostic delay of about 3 to 4 years, especially in non-endemic regions like Singapore. So transthyretin gets its name from being a transport protein for thyroid hormone and retinol binding protein. It is mainly produced in the liver, with small amounts still synthesized in the retina and the choroid plexus. The transthyretin normally circulates in a stable tetramer of 4 TTR proteins, but mutations in the TTR gene leads to dissociation of the tetramer into monomers, which then misfold and aggregate into amyloid fibrils. These fibrils deposit in the organs and cause damage by ischemia, mechanical compression, and potentially inherent toxic effects. We see here the typical pathological features of amyloid in the nerve, which is congophilic or stains brick red on Congo stain, and it also shows an apple green birefringence with polarized lights. Amyloid deposits have been found throughout the neural axis and in the connective tissue of nerves as well. Evidence of disruption of the blood-nerve barriers have also been found on electron microscopy, and this allows entry of the circulating TTR into the endoneural space and its resultant toxic effects. Genetics-wise, there are more than 150 different TTR mutations, which you can actually refer to this website here. Worldwide, the most common mutation is a substitution of methionine for valine at position 30, or the ATTR-Val30-MET mutation. On the right here, we see how certain TTR mutations are associated predominantly with endoneural deposition, and which results mainly in neuropathy. Most commonly is the Val30-MET mutation, while the other mutations the cardiologists may be more familiar with because they are associated with a predominantly cardiomyopathic or a mixed phenotype. In terms of local genetics, Singapore is a multiracial society, and we do have patients from the region seek medical treatment in Singapore. This study from Tan Dok Seng looked at 29 multiracial patients. The majority of patients were ethnic Chinese and had the same mutation as what is seen in the ethnic Chinese in China and Taiwan, or the ALA117 serine mutation. There is great phenotypic heterogeneity between regions, genotypes, and even within the same mutation. For example, Val30Met amyloidosis can manifest as an early disease onset in endemic regions, while individuals of similar ancestry in non-endemic regions and with similar mutations may have an older onset of disease. The degree of penetrance is also highly variable. For example, an early onset Val30Met penetrance may be higher at an earlier age in Portugal than in Sweden. And these differing presentations may be due to the effect of genetic as well as non-genetic modifying factors. Neurology manifestations of TTR can be classified as either occurring in the peripheral or central nervous system. Peripheral nervous system involvement is more common. Myopathy and spinal stenosis are not as well described in the literature, but spinal stenosis at the lumbosacral region is a common occurrence because of infiltration of the amyloid into the ligamentum flavum, causing neurogenic claudication. The hallmark of peripheral nervous system in amyloidosis consists of a triad of carpal tunnel syndrome, autonomic neuropathy, and peripheral neuropathy. The carpal tunnel syndrome in inherited transthyretin amyloidosis tends to be more severe and bilateral, and recurs and progresses even after surgery is performed. Autonomic dysfunction is related to the peripheral neuropathy and can lead to gastrointestinal symptoms and drastic weight loss, which is also a hallmark of this disease. The presentation of ATTR polyneuropathy can differ depending on whether it is early or late onset. In typical early onset disease, there is selective distal loss of pain and temperature sensation before the larger sensory and motor fibers are affected, causing a pansensory loss and motor weakness. In typical late onset disease, the pansensory loss and motor weakness occurs much earlier in the disease course. Autonomic neuropathy can also occur in a large proportion of patients, to a more severe degree in patients with early onset disease. And some of the symptoms include orthostatic hypotension, gastroparesis, alternating constipation and diarrhea, urinary retention, and erectile dysfunction. Autonomic neuropathy has a high morbidity from arrhythmias and sudden death. Atypical presentations include presenting as a polyradiculoneuropathy, just as an earlier upper limb onset with just a pure motor weakness, as a rapidly progressive phenotype, and as an ataxic phenotype with little weakness. And we typically see these atypical presentations in neuropathy more in late onset disease rather than early onset disease, as well as in non-endemic regions like Singapore rather than endemic regions. Early diagnosis of ATTR neuropathy is therefore challenging, especially in non-endemic areas, where a majority of cases have no family history and variable and atypical presentations. In this study, this Italian group studied 150 patients with ATTR diagnosed over 14 years and listed some of the various initial misdiagnoses some of these patients had. CIDP was one of the most common misdiagnoses, or chronic inflammatory demyelinating polyneuropathy, and this is because the electrodiagnostic features not infrequently satisfy CIDP criteria on NCS, and even the CSF or cerebrospinal fluid protein can be elevated on lumbar puncture, which is what one also sees in CIDP. In fact, amyloidosis in the neurology world is known as the great imitator and can mimic many other neurological diseases such as ALS or motor neuron disease, as shown here where the patient with amyloidosis actually has a wasted and fasciculating tongue just like in motor neuron disease. We therefore have to keep in mind a list of red flag symptoms for inherited transthyretin amyloidosis to improve its recognition. This includes looking out for positive family history, the triad of neuropathic symptoms or carpal tunnel syndrome, neuropathy, and autonomic dysfunction, association with other constitutional signs and symptoms of systemic involvement, and if you have a progressive polyneuropathy of uncertain etiology or which is rapidly progressive, or if you have features of an atypical neuropathy such as predominant motor weakness, rapid rate of progression, or lack of response to treatment. Considering that the disease is now relatively treatable, there should be a lower threshold of considering the disease, and it's now suggested that the disease should be considered in patients with a neuropathy, plus at least one of the previously stated red flag symptoms suggestive of multisystemic involvement, or if they have a family history of cardiac or neuropathic symptoms. This is a currently recommended workflow in the US for diagnosis of ATTR amyloidosis with neuropathy, and we follow this fairly closely in NUH. Patients are assessed for alternative etiologies of neuropathy, such as screening for B12 deficiency or diabetes, or AL amyloidosis with an Ig-free light chain assessment. Tissue biopsy diagnosis may be useful if there are concurrent alternative causes of peripheral neuropathy, such as diabetes or B12 deficiency. If there's no alternative cause for the neuropathy, tissue diagnosis may not be necessary, and an alternative supportive means of investigation with cardiac scintigraphy may be helpful to support the diagnosis. In this workflow, the cardiologist and cardiac technetium scintigraphy takes on a role of importance because a positive scintigraphy may help make the diagnosis of ATTR amyloidosis without the need for biopsy. If there is a sufficiently positive uptake indicating the presence of TTR, if there is no monoclonal gammopathy, which may give a differential of AL amyloidosis, and especially if there's a confirmed TTR genetic variant without the presence of an alternative cause of peripheral neuropathy. I show an illustrative case. This was a 55-year-old man with recurrent spinal surgeries for spinal stenosis, had a left rotator cuff tear, and had hearing loss. At the same time, he had drastic loss of weight and was actually scanned extensively for underlying malignancy. He developed postural hypotension about 25 years after his first spinal surgery, and this was initially attributed to dehydration and drugs. As part of the giddiness workup, he was found to have cardiac hypertrophy on 2D echo, but it was thought non-specific and he was discharged from cardiac follow-up. He was finally referred for electrodiagnostic studies because his numbness was not better post-spinal surgery. History revealed that he had symptoms suggestive of autonomic dysfunction, such as reduced sweating and gastrointestinal symptoms, and he had a family history where both his father and paternal aunt died following dramatic weight loss. Physical examination was consistent with a polyneuropathy, and nerve studies showed bilateral carpal tunnel syndrome with severe polyneuropathy. This case fulfills the following red flags. He had positive family history. He had an association with the other triad of neuropathic symptoms and signs, namely which was the neuropathy, carpal tunnel, and autonomic dysfunction. He had systemic involvement with the heart and weight loss, and he had other minor clues to the diagnosis, such as musculoskeletal manifestations of the rotator cuff tear, lumbar spinal stenosis, as well as sensory neural hearing loss. He underwent a nerve biopsy, and here we see his sural nerve with an amorphous deposit, which appears the classical brick red on Congo red stain and shows apple green birefringence on polarization. He therefore went on to test for genetics, and he was positive for the arginine 54-threonine alteration, and he was started on fludrocortisone and diflunisal with slowing of progression of this condition. And I think this case illustrates how noting red flags when diagnosing cardiac hypertrophy in a patient can be helpful for the eventual diagnosis of ATTRV. CNS involvement is also one of the manifestations in ATTRV. And neurological symptoms include headaches, hearing or vision loss, cerebral hemorrhages, dementia, ataxia, or transient focal neurological episodes that may mimic stroke or seizures. Patients with VAL13-MET mutation that are treated with liver transplantation tend to be the ones that may go on to develop leptomeningeal amyloidosis because the patient lives longer and the TTR is still secreted from retinal cells and the choroid plexus to cause amyloid deposits. We also see CNS involvement in non-VAL13-MET mutations that have milder phenotypes and a longer survival. The MRI may show leptomeningeal enhancement and superficial siderosis as a sequelae of subarachnoid bleeding due to the amyloid deposits. To give you an idea of the spectrum of ATTRV patients neurology has seen in our cohort, we have seen more males than females. Our main genotypes are alanine 117 serine and arginine 54-threonine, and 40% would have the full triad of PNS involvement. And how this illustrates the close collaboration I have with the cardiologists. 100% of them all have cardiac amyloid. 40% of them had declined treatment, although the majority are on diflunisal for their polyneuropathy. We go on to the other types of amyloidosis. The other two most common forms of systemic amyloidosis are the monoclonal immunoglobulin light chain amyloidosis, or AL amyloidosis, as well as the wild type transdirectin amyloidosis. For AL amyloidosis, it has an estimated prevalence of 2.5 per 100,000, and Sanjay has already gone through the pathophysiology of AL amyloidosis. Peripheral nervous system involvement seen in transdirectin amyloidosis is also seen in AL amyloidosis, again with the triad of peripheral neuropathy, autonomic neuropathy, and carpal tunnel syndrome. When we compare the neuropathy that occurs in both types of amyloidosis, pan-neuronal involvement involving the motor nervous system happens to occur earlier and more often in TTR rather than AL cases. However, non-neuronal organ involvement, such as the heart, is actually more often seen in AL cases than TTR cases, with better survival in the TTR cases compared to the AL cases, as illustrated in this Kaplan-Meier curve here. Other than peripheral nervous system involvement, the involvement of the heart and gastrointestinal symptoms is common to both inherited transthyretin amyloidosis as well as AL amyloidosis. Unlike transthyretin amyloidosis, AL amyloidosis has no central nervous system involvement and has the additional features of periorbital purpura, macroglossia, liver, as well as kidney dysfunction. Other differences are that AL amyloidosis tends not to have ocular manifestations or biceps tendon rupture. Amyloid myopathy is also more likely seen in AL amyloidosis than transthyretin. Nearly half of AL amyloidosis patients had at least one neurological manifestation, of which amyloid myopathy makes up about 4%. Male gender and cardiac involvement were also independent predictors of the presence of peripheral neuropathy and autonomic dysfunction. AL amyloid myopathy is usually seen in association with other organ involvement, such as the heart. And the tricky thing is that a significant proportion may have a normal CK level, although a majority may have muscle weakness. Like transthyretin, there are also atypical presentations of AL amyloidosis, which can make the diagnosis challenging. And this includes presentations of multiple cranial or peripheral mononeuropathies, again, a CIDP phenotype, a lumbosacral radiculoplexoneuropathy. I have an illustrative case. This 72-year-old presented with a month of progressive muscle weakness, dysphagia, and weight loss. Initially, he was thought to have a myositis based on an irritable myopathy seen on EMG, but myeloma panel was positive for IgG lambda band, and 2D echo importantly showed signs suggestive of a cardiac amyloidosis. Muscle biopsy showed AL amyloidosis, and BMA and trophine also confirmed the diagnosis of a plasma cell dyscrasia, and he was eventually diagnosed with multiple myeloma. Unfortunately, after that, he developed nephrotic range of proteinuria and renal failure, and shortly demised after. So again, he fulfilled some red flags which may suggest amyloidosis when seen in association with a neuromuscular syndrome. He had a progressive myopathy with unexplained constitutional symptoms of weight loss, associated heart disease and proteinuria, and importantly, he had the presence of a monoclonal gammopathy. The case also illustrates the diagnostic components associated with the suggested diagnostic algorithm for amyloidosis. Like transthyretin, again, we assess for red flag symptoms and screen for alternative etiologies other than amyloidosis. Tissue biopsy can be pursued, whether it's with bone marrow biopsy, fat pad biopsy, or tissue biopsy of involved organs. Cardio input is also important to determine if there's cardiac involvement, and endomyocardial biopsy can be pursued if there's cardiac involvement. Cardiac scintigraphy and genetic testing may be helpful to rule out the differential of transthyretin amyloidosis. Last of all, for wild-type amyloidosis, peripheral neuropathy is less common, and there's been no nerve biopsy-proven case of ATTR wild-type amyloid neuropathy. There have been some case reports of myopathy, but generally, as seen in this sum-up slide, cardiac and neurologic manifestations are the most common, actually more in the AL as well as the transthyretin inherited transthyretin amyloidosis, while cardiac symptoms are actually more common in the wild type as compared to the neurologic. So I'd like to suggest why one may want to consider a neurology assessment if your patient has the suspicion of cardiac amyloidosis. If you find concomitant neurologic involvement, it's a red flag that may point towards the diagnosis of amyloidosis. And we can offer symptomatic treatments for peripheral neuropathy and autonomic dysfunction. And there are now also treatments approved for ATTR-PN or peripheral neuropathy, which is not yet approved for ATTR-CM. And neurology input therefore may aid with the multidisciplinary monitoring of the disease progression. As an example of how multidisciplinary approach works, this is the Swiss guidelines in 2021 for the recommended assessment tools of ATTR-V amyloidosis. It involves the neurologist, the cardiologist, the kidney doctor, the ophthalmologist, the gastroenterologist, as well as counselors for psychological well-being. Multidisciplinary monitoring and management is therefore important to assess whether other organs are affected, either by amyloid deposition or by autonomic dysfunction. And the need for multidisciplinary care has been reaffirmed in consensus recommendations. The benefits of multidisciplinary care that we have found includes expedited referrals for suspected cases of amyloidosis, multidisciplinary decisions on best choice of management, and better holistic care for patients, as well as better monitoring of at-risk family members for those who have inherited transthyretin amyloidosis. And just as a taste of what drugs are used for ATR VPN, which is now also the hot topic in the realm of ATTR-CM, there are the TTR silencers that reduce the production of TTR, whether by antisense oligonucleotide therapy such as inotersen or eplontersen, or RNA interference therapeutics such as patisiran and vutrisiran. So some of my take-home points. Keep in mind the triad of peripheral nervous system manifestations for both ATTR as well as AL amyloidosis, which are namely the polyneuropathy, carpal tunnel syndrome, and autonomic dysfunction. Although keep in mind that there are some clinical differences between the two. Remember that there are atypical presentations of amyloid neuropathy, of which CIDP is a common atypical presentation. We should have a lower threshold of genetic testing of idiopathic peripheral neuropathy, given now that there's treatment availability for inherited transthyretin amyloidosis. There are symptomatic managements for peripheral neuropathy and autonomic dysfunction, which can be offered to patients. And we hope that we can also help with multidisciplinary monitoring and care. So I thank you, and you can also similarly email me or put in the question chat for questions. Thank you.
Okay, thank you, Dr. Ng. So our last speaker is Associate Professor Xiao Sui Chong. He is our in-house electrophysiology guru at the National University Heart Centre, Singapore. His subspecialty interests would be heart failure and electrophysiological problems in patients with cardiomyopathies, heart failure. And he's going to talk to us about electrophysiological problems that we often encounter in patients with cardiac amyloidosis. Sui Chong?
Thanks very much, Wei Jin. Hope you guys can see my slides. So I'm tasked to talk to you about electrophysiological problems that you might encounter in cardiac amyloidosis. And after two very academic talks, mine would seem relatively simpler. And I shall go through this in a fairly layman kind of fashion so that everyone can follow. So amyloidosis, as you already know, is a systemic disease. And the problem is with the deposition of abnormal protein fibrils in various organs. And I realize that my percentages are a little bit different from what's been quoted, but it is, in the cardiac literature at least, about 20% of patients have cardiac involvement at the point of diagnosis. And it's thought that the heart is involved in about 60% of amyloidosis. In autopsy studies, looking at patients with heart failure with preserved EF above the age of 75 years old, is found that about 30% of these patients had heart failure due to underlying ATTR. So most of cardiac amyloidosis is due to either light chain disease or transthyretin type, which can be further subdivided into the wild type or senile ATTR versus hereditary ATTR, which is due to a genetic mutation. So I think as far as the heart is concerned, transthyretin and light chain disease are not quite the same, in that the transthyretin variant tends to behave more like a chronic progressive kind of cardiomyopathy, where there's a slow deposition of amyloid within the myocardium and conduction system. And on the other hand, light chain disease is a bit more aggressive. It tends to behave more like an acute myocarditis, where there is early onset of symptoms and rapid progression to heart failure. This is thought to be due to the toxic effects of the light chain amyloid. And how does it result in, arrhythmia problems? There are two main mechanisms. The first is through the mechanical effect of amyloid deposition within the myocardium. So essentially, there is infiltration of the myocardium by all these abnormal protein fibrils, and this results in a restrictive cardiomyopathy. So the thickened walls of the myocardium do not relax so well, and this leads to elevated pressures within the chambers. This leads to myocardial stretch and subsequently chamber enlargement. For example, the left atrium can be enlarged. And this, of course, affects the conduction properties of the myocardium, and this results in atrial fibrillation. The other thing which happens with amyloidosis is, of course, the deposits themselves also impair electrical conduction and give rise to electrophysiological problems. So the presence of arrhythmias in patients with amyloidosis has been shown to be an important predictor of bad outcomes, mortality. And the main arrhythmias that you see would be atrial fibrillation, which is seen in up to 70% of patients with cardiac amyloidosis, conduction disease, and ventricular arrhythmias. So apart from atrial fibrillation, which is fairly common, we can also see atrial flutter and atrial tachycardia. So as I mentioned earlier on, up to 70% of patients with cardiac amyloidosis suffer from atrial fibrillation. And this is more commonly seen in patients with transthyretin amyloidosis rather than light chain, probably due to the progressive nature of transthyretin amyloidosis that allows time for them to develop atrial fibrillation. So essentially, you have elevated atrial pressures, atrial dilatation, and that causes creates the substrate for atrial fibrillation. And the infiltration of amyloid deposits themselves into the atrial tissue messes with the depolarization and repolarization timing and predisposes to AF. Of course, one of the contributory factors is also the older age of patients with transthyretin amyloidosis. And age is a risk factor for atrial fibrillation. So in these patients, pulmonary vein triggers or ectopic atrial triggers may play less of a role. And therefore, the benefit of pulmonary vein isolation and ablation is less clear in this patient, right? Because in amyloidosis, it would seem that the AF results more from diseased atrial substrate rather than triggers that initiate the AF. There is an entity that's called isolated atrial amyloidosis that sometimes the surgeons see because they, after bypass, they excise the left atrial appendage and find that there's amyloidosis within that appendage. The significance of it is not known, but it could be one of the reasons for atrial fibrillation. So in patients with cardiac amyloidosis, AF is usually highly symptomatic and poorly tolerated. And that's because of the underlying restrictive cardiomyopathy that results from amyloid deposits. So the poor systolic output results in a compensatory increase in baseline heart rate. So if you then try to control the heart rate with AV nodal blocking drugs, you may cause decompensation. So beta blockers, calcium channel blockers, and digoxin, when they're given, may result in decompensation because you may block off that compensatory increase in heart rate. And it's going to be a very difficult management problem because on the one hand, you cannot allow the ventricular rates to go too fast in the setting of AF because it would worsen the systolic function of the ventricles. On the other hand, if you give these AV nodal blocking agents, you may cause relative bradycardia that results in decompensation. So relative bradycardia because they need a higher baseline heart rate to sustain the cardiac output. And now you are attenuating that with the drugs. The use of digoxin is also controversial because it tends to bind avidly to the amyloid fibrils, and this predisposes to toxicity. The silver lining on the cloud, though, is that AV nodal conduction may actually be slower in the setting of cardiac amyloidosis because of disease, right? Because of infiltration of amyloid into the conduction system that paradoxically help things because it slows down the conduction. If atrial fibrillation cannot be controlled, then the last resort is to ablate the AV node and implant a pacemaker. If pharmacological therapy is pursued, then amiodarone seems to be quite well tolerated, and failing which sotalol can also be considered. But typically, it's difficult to rate control atrial fibrillation. The other issue that's somewhat associated is the problem of thromboembolic risk. We know that cardiac amyloidosis by itself is associated with a high thromboembolic risk. And this has been attributed to various reasons like reduced atrial contractility, stasis, endothelial dysfunction, and hypercoagulable state due to the amyloidosis. In fact, in doing transesophageal echoes in these patients, atrial thrombi have been found, even in those who are in sinus rhythm. And you can imagine that if these patients have AF, it would elevate the risk of thromboembolism even further. In studies that looked at CHEST-VAS score and the presence of left atrial appendage thrombus on transesophageal echo, there seemed to be no correlation between the score and the presence of clot. You would think that the higher the score, there should be a higher chance of clot, but there doesn't seem to be such a correlation, meaning that patients with cardiac amyloid are all at high risk of thromboembolism. With that in mind, then, any patient with cardiac amyloidosis who has atrial fibrillation should be anticoagulated regardless of the CHEST-VAS score, right? So even if the CHEST-VAS score is 0 or 1, they should be anticoagulated because these are all patients at high risk of thromboembolism. So this review looked at studies that where there was transesophageal echo performed in patients with cardiac amyloidosis before cardioversion from AF to sinus rhythm. And they found that about a third of them had thrombi in the left atrium. And of all those who had thrombi in the left atrium, about half of them had been on therapeutic anticoagulation for more than 3 weeks, or had the duration of AF less than 48 hours. So you would know that the guidelines tell us, if you're going to cardiovert someone for AF, if the AF has been there for less than 48 hours, or if you've anticoagulated them for at least 3 weeks, it's okay to cardiovert them without a TEE. But it doesn't seem to apply for patients with amyloidosis because half of them had thrombi despite fulfilling either of these criteria. In a different study, they found that 88% of those who had the intracardiac thrombus had actually been therapeutically anticoagulated for at least 3 weeks prior. So the take home then is, if you intend to cardiovert these patients with cardiac amyloidosis, you should always do a transesophageal echo, despite the adequacy or duration of anticoagulation, simply because they are at such a high risk of thrombus formation. What about catheter ablation for AF and AT? So the standard procedure for ablation for AF is to isolate the pulmonary veins, and sometimes we may add additional lines to try and replicate the Cox-Maze lesion set to improve the chances of success. So these studies, which have been done on limited number of patients, show that the ablation for AF and AT is feasible, but there was a much higher risk of recurrence. And on mapping the left atrium, they found that there was extensive conduction disease within the myocardium. So this is not surprising because of the involvement of the myocardium by amyloid deposits. So in these cases, as I alluded to earlier, the role of pulmonary vein triggers is not so clear, and therefore isolating the pulmonary veins may not be so effective for eliminating AF, because this is more a substrate-driven kind of disease rather than trigger-driven kind of disease. Atrial flutter can also be seen in patients with amyloidosis because of the enlarged right atrium. So I mentioned earlier that you have a restrictive cardiomyopathy. So this, of course, results in raised atrial pressures and dilated atria, including the RA. And if you've got dilated RA, you have essentially the substrate for re-entry and atrial flutter. So it's preferred that we perform ablation in these cases to restore sinus rhythm, partly because rate control is problematic, and also because ablation is simple to do and highly effective at 90% success rate. Ventricular arrhythmias can also be seen in patients with cardiac amyloidosis. PVCs are common, and VT and VF a bit less frequently seen in about 19%. And they carry prognostic implications. Obviously, if you have ventricular arrhythmias, then the outcomes are not good. And ventricular arrhythmias tend to be more common in light chain disease, probably because of its aggressive course and its steep downward path. And there are many multiple potential mechanisms that give rise to ventricular arrhythmias in amyloidosis. The deposition of amyloid within the myocardium, because it blocks conduction, can result in re-entry circuits. It can be myocardial ischemia due to amyloid infiltration of capillaries. There can be autonomic imbalance because of the autonomic nerves being affected by amyloid deposits. And all these are things that predispose to ventricular arrhythmias. So then, what should we do, right, to try and prevent these patients from dying suddenly? And the risk stratification has proved to be rather challenging. Biomarkers have not been so helpful. MRI, which is pretty useful for cardiomyopathy for risk stratification in non-amyloid patients, doesn't seem to be so helpful in the setting of cardiac amyloidosis because late gadolinium enhancement, which typically should show us scar burden, is caused not just by scar in this case, but also by amyloid as well. So if you see a lot of LGE on MRI in the patients with cardiac amyloidosis, it's not just scar that's showing up, but areas that have infiltration by amyloid. And although the extent of amyloid deposits may be prognostically important, it's not clear whether the presence of amyloid is prognostically the same as the presence of scar. So for example, if you have a patient with MRI showing 20% scar burden, you know that the risk of ventricular arrhythmias is high. But if you have somebody with no scar, but 20% amyloid deposition, does that confer the same amount of risk? And that's something we do not know. We do know, however, that amyloid deposition causes some changes in the myocardium, which is similar to what you might see with scar. That is, fractionation of signals, slow conduction, and spatial dispersion of repolarization, which are all things that predispose to re-entry and ventricular arrhythmias. What about EP study? So sometimes we may perform a VT stimulation to see whether there is any inducible monomorphic VT, and if there is, then this might be a reason to implant an ICD. And unfortunately, in the setting of amyloidosis, EP study has not been shown to be very useful. So because of all these reasons, primary prevention ICD is controversial in the setting of amyloidosis, because the most common cause of sudden death is actually electromechanical dissociation rather than VT or VF. The other thing to consider is that in amyloidosis, the defibrillation threshold can be elevated, which could make the ICD shocks useless. And lastly, a lot of these patients with cardiac involvement tend to have a poor prognosis and short life expectancy. So it may not be reasonable to implant an ICD for these patients. So indeed, there were some older studies where ICDs were implanted for the purpose of primary prevention. And you can see that in all these patients, the rate of appropriate ICD therapy was pretty low, from 6.5% to maximum 32%. And there didn't seem to be any apparent improvement in survival with the implantation of primary prevention ICD. So as such, only the 2019 HRS guidelines kind of like recommend with a 2B indication, primary prevention ICD in patients with light chain amyloidosis who have non-sustained ventricular arrhythmias. But this is a soft recommendation, 2B. That means can be considered, but may or may not help. When it comes to secondary prevention, it's a bit easier. So anyone who has had a documented VT or VF would qualify for ICD, albeit with a 2A recommendation only in the ESC guidelines, but this was given a class 1 recommendation in the American HRS guidelines. We come on then to conduction disease, and amyloid can affect the sinus node, the AV node, and the bundle branches. So deposition of amyloid in and around the SA node can result in malfunction of the SA node, which can then fail to fire and you get sinus pauses. AV conduction system can also be affected by the deposition of amyloid. And of course, this results in conduction block, conduction failure, and the transthyretin variant of amyloidosis tends to feature more prominently in this department, probably because of the chronicity of the disease. So you may see left bundle branch block, right bundle branch block, infrahesian block, but whatever it is, if they have AV block, then they have earned themselves a pacemaker. So as I alluded to, the rate of pacemaker implantation seems to be higher in transthyretin amyloidosis, probably because of the longer duration and chronicity of the disease. Whereas, light chain disease may actually kill off the patients before they reach the stage where they need a pacemaker. So when it comes to pacing, obviously, if they have heart block, second degree or high grade or third degree AV block, they would warrant a pacemaker implant. And the guidelines for implanting a biventricular device is the same as for other patients, i.e., if they've got low EF, left bundle branch block pattern, and a requirement for high amount of V pacing, then a bi-V device may be considered. So there's no role for prophylactic pacemaker implantation, okay? Although this was suggested in this article, but there's no proven benefit. So in conclusion, arrhythmias are quite common in amyloidosis, namely atrial fibrillation. And if there is atrial fibrillation, anticoagulation is of vital importance with cautious rate control. And rhythm control may be preferable with amiodarone or with cardioversion, but making sure that we've got a TEE done before cardioverting and also to anticoagulate. There's a limited role for ablation because the mechanism is just not the same. Ventricular arrhythmias would earn a secondary prevention ICD, but there's no role for primary prevention. When there's bradyarrhythmia due to conduction system involvement, we will implant a pacemaker for significant sinus node dysfunction or AV block. And there's no proven benefit for prophylactic pacemaker implant. Thank you. That's all I have.
Okay, thank you, Swee Chong. So we have, I think, about 15-20 minutes for a Q&A session. I do see some questions on the in the chat box, in the Q&A box. So let's try to clear all the questions one by one. So there's a question saying about diflunisal. So does diflunisal have end-state functions? Was it the reason why it was discontinued by FDA? What's the role of diflunisal in the treatment of transthyretin amyloidosis? Maybe I direct this question to Dr. K. Ng. Many of the patients have been prescribed diflunisal. What's her take on this?
Yes, so you're right to say that diflunisal is actually an NSAID. It's a salicylic acid derivative, and it acts as a TTR stabilizer. Its utility actually was seen more in a phase 2-3 trial in Sweden quite some time ago, I think more than 10 years ago. It actually was not discontinued because of safety considerations. I think it was more for economic reasons, as in the company no longer wanted to produce it in US, but we actually have the generic form quite available in other countries. We actually bring in our stock from Canada, and I believe Tan Tock Seng also has diflunisal on its formulary.
What do you think is the role of diflunisal in patients with transthyretin amyloidosis? Do we even need to give diflunisal? What's the role in peripheral neuropathy patients?
So the trial actually showed stabilization of the NIS plus 7, which is actually a functional scoring of the neuropathy score. So I think the practice Actually, it's actually quite widely used in the US because my understanding is that tafamidis is actually not FDA approved for the peripheral neuropathy bit in the US. So even though it's not the brand name is not available in US, but the generic is actually available in the US. So they use diflunisal actually quite widely to try to plateau the patients. And literature has been published anecdotally of how experts use the drug. They primarily use it as early stage as possible, or FAP stage 1, to try to plateau the patients as long as possible. And then when it deteriorates, that's when they will start to consider the RNA silencers or the antisense oligonucleotides. So because the study only kind of looked at peripheral neuropathy, so there's not much data as to, or there's no data at all published actually as to the effect on the heart. Although it's probably not encouraged when you already have heart failure or heart involvement, primarily because it does, I mean, as mentioned, it's actually an NSAID. Yeah, so I think the idea would be to try to start it as early as possible, because theoretically it should also have some impact on the heart, and is to try to plateau the patients as long as possible. And if they start to deteriorate, then start to think about whether you should offer antisense oligonucleotides or RNA silencers, although of course the cost is prohibitive in case of Singapore.
So yeah, I think you mentioned it. Heart failure is always a concern in patients with more advanced cardiac amyloidosis, and NSAIDs and heart failure, they don't really go well together. And again, many elderly patients also have some form of renal dysfunction, and NSAIDs is really not appropriate in this group of patients. So in Singapore, we are lucky that now the families is getting better subsidy, is more accessible to the general public. So I guess over time, as the family's price drops, the use of diflunisal probably will come down, especially in the cardiomyopathy subgroup of patients.
Yeah, I think the issue for tafamidis is that for Singapore, it's not currently covered under MAF for stage 1 neuropathy. While actually it is recommended in other non-US countries such as the Europe. Yeah, so we haven't been able to get MAF subsidy cover for neuropathy for tafamidis for our neuropathy patients. They have to have cardiomyopathy before we can prescribe tafamidis.
I guess things might change in the future when it becomes cheaper or generics are available, or there are new compounds coming up in the market, especially the silencers. Yeah. Okay, so let's move on to the next question. Does amyloid increase with age? There's a question on beta amyloid and the risk of heart failure. So beta amyloid, I understand, is associated with dementia, Alzheimer's disease. I don't think it has any, we do not see beta amyloid being deposited in the heart. The heart is usually just transthyretin and light chain amyloidosis. And heart failure, I guess it increases with age. The incidence of heart failure increases with age. So I don't think it's a direct beta amyloid, deposition in the heart causing heart failure. It's probably just an association. I actually had a brief look at the article that was attached to the question. So I think it's more of an association. I don't think that it is directly cardiac amyloidosis from this subgroup amyloid. Okay. Then next question is for Dr. Xiao. If the AV conducts slowly, this will not be able to keep up with the demands of the patient. So is this a question? I think it's a question on pacemaker. When do we consider pacemaker in patients with bradycardia, besides just a high-grade AV block or complete heart block? Patients in sinus rhythm, is there a time where we need to consider putting in a pacemaker?
Not really. I think the guidelines basically do not apply differently for patients with amyloidosis. So if you've got significant sinusal dysfunction, meaning that you've got pauses that result in symptoms of syncope, presyncope, or you've got chronotropic incompetence, these patients are just unable to do anything strenuous, then you would consider a pacemaker. And for AV block, of course, if there's infrahisian disease, or if there's high-grade AV block or complete heart block, you would implant a pacemaker. But I think the questions that's being asked probably reflects a misunderstanding of what I tried to say. And maybe I'll just reiterate again what I mentioned earlier, and that is that when the patients have this restrictive cardiomyopathy, there's impaired cardiac output, impaired forward flow. And so the patient compensates with an increased heart rate, right, ordinarily, to try and make up for this reduction in cardiac output. So when you have atrial fibrillation, then you have a problem where sometimes the ventricular rate can be very fast. For example, 150, 140, and there can be other times when the ventricular rate is very slow. So on the one hand, you want to prevent a situation where the ventricular rate is very fast, because sustained tachycardia results in the impairment of the EF, right, because of tachycardia-induced cardiomyopathy, and it worsens things. On the other hand, if you give AV nodal blocking agents, you cannot control times when the heart rate drops too low. And for the patient with cardiac amyloidosis, too low can be 60 beats per minute. So 60 beats per minute might be okay for ordinary person, normal person, but it may not be okay for someone with amyloidosis, because he needs a higher heart rate to maintain his cardiac output. So that's what I meant by relative bradycardia. But on the other hand, the infiltration of the AV conduction system causes some degree of AV block. And so that is, in a way, autoprotective, because then the ventricular rate may not go so fast. So I think that's what he's trying to ask.
So similar, so another question kind of related. I have a few patients with pacemaker because of complete heart block with cardiac amyloidosis. And there is often a comment saying that the pacemaker threshold, the lead thresholds are exceedingly high.
Yes.
When we implant pacemakers, how often do we see this threshold being very high? Is this a red flag for cardiac amyloidosis when we implant pacemakers then?
To be honest, I haven't implanted pacemakers in so many patients with cardiac amyloidosis, but you certainly can understand why the threshold might climb over time, because at the point of implant, it may be fine, but because this is a progressive disease, over time there can be deposition of amyloid around the pacing lead, and of course, this is an insulating material that would prevent you from being able to capture the myocardium at a reasonable output. So I don't think there's any way to prevent this, but to know that this happens, and to be on the alert that if the thresholds go too high and you are at risk of losing capture, then we may have to just pull this patient back and then perhaps reposition the lead elsewhere.
Okay, maybe we move on to the next question about anticoagulation. I think it's a very difficult question. Is there any role for anticoagulation in amyloidosis and sinus rhythm?
We don't have an answer to that question because we don't know, right? Because we know that amyloidosis in and of itself is a risk factor for clot formation within the atrium. But at what point does it justify giving anticoagulation to try and counteract that? I do not know, because you don't have a scoring system to evaluate this. And the other difficulty is that, is anticoagulation actually effective in these patients compared to those without amyloidosis? Again, we don't know. And the reason for asking this question is because I mentioned earlier in my talk that, up to 88% of patients in one study, right, who had a thrombus on TEE actually had been on more than 3 weeks of anticoagulation, therapeutic levels of anticoagulation, and yet they had a clot. Does that mean that anticoagulation is not effective in patients with cardiac amyloidosis? It could be. Or does it mean that we have to aim for a higher, INR if you're using warfarin? And do we routinely, therefore, also, because like the question suggests, do we routinely anticoagulate anyone with cardiac amyloidosis? I don't know, because it has to be weighed against the risk of bleeding with anticoagulant. No answer.
Okay, maybe I'll direct the next question to Kay. So there's a patient with TTR amyloid who was previously on tafamidis and inortresin for cardiac and neurological involvement. Inortresin was stopped because of renal side effect. And what is your experience and what's your take on gene silencing therapy for this group of variant patients with mixed phenotype? Okay.
Okay, thanks for the question. So inortresin has a black box warning for two main problems, which is thrombocytopenia and glomerulonephritis. It's also subcutaneously administered, which is why it may be attractive over what was previously available in the gene silencer of patisiran, which is intravenous and has to be given every 3 weeks. So that was the attractiveness of inortresin. But now, along the same lines of the gene silencing, in the same gene silencing family, there's now vutrisiran, which is also a subcutaneous option, and it's can be administered every 3 months. We've not had experience, and to my knowledge, I don't know anyone in Singapore who has experience with vutrisiran. Although I've been in touch with the drug company and they're working on actually getting it in. We've been using patisiran mainly also because of insurance claims issues, because it's intravenously administered, while vutrisiran is going to be subcutaneously administered. But generally, I think the RNA silencers actually have a benefit over the gene silencers actually have a benefit over inortresin because it's actually fairly well tolerated. It doesn't have the glomerulonephritis, the thrombocytopenia. It's primarily hypersensitivity reactions, which can be quite well managed with dexamethasone as well as antihistamines. So that was primarily our choice of choosing patisiran over inortresin initially. Although my understanding is that the new drug along the same lines of inortresin or eplontersen actually now no longer has these major side effects of glomerulonephritis or thrombocytopenia. Actually, it's much reduced. It's also subcutaneous involved. So I think choosing a choice of therapy for the neuropathy actually was probably going to be shared decision making between the physician as well as the patient, whether like insurance, pricing, subcutaneous, how often they can get it, whether they can accept the side effect profile. So I think if they can no longer take inortresin and they can afford it, there are definitely still other choices. You can choose eplontersen or vutrisiran if they still want subcutaneous options.
Okay. So I'll take the next couple of questions. What are your thoughts on SGLT2 inhibitors for ATTR cardiomyopathy? So we do not have randomized data for SGLT2 inhibitors for ATTR cardiomyopathy. In fact, for most of our HFpEF or mildly reduced EF clinical trials, the trial design has been specifically targeted at ruling out ATTR cardiomyopathy before recruitment. They really don't want their HFpEF population to be contaminated by a group of amyloid cardiomyopathies, which was the thought why previous HFpEF trials were negative, because they included all these amyloid patients. But there have been some subsequent registry data or single center, not very powerful data, but nonetheless suggestive that SGLT2 inhibitor as a class of medications can reduce the risk of heart failure in patients with ATTR-CM and problems with volume overload. Of course, it is quite safe to use. It's probably not a bad idea to try it out on patients on top of the usual MRAs. SGLT2 inhibitors plus loop diuretics can be a strategy for patients who are struggling with heart failure with ATTR-CM. So can try, not a bad idea. The second question I'll address would be, how early will you do technetium pyrophosphate imaging scan? So I'm not sure what that really means, but I suppose it's in the setting of a variant patient, a gene positive patient. So gene positive patient, how do we follow up this group of patients? It's controversial. We have no treatment for gene positive patients to prevent the onset of disease, although in the future there might be some clinical trials running looking at stabilizers in gene positive patients before they develop disease. When do I do PYP scan for this group of patients? We try to identify them with family screening once they are gene positive, depending on their age. If they are in their 20s or in their 30s, I really don't want to expose them to unnecessary radiation. And to be honest, if you diagnose a 20 or 30-year-old with a positive PIP scan, what can we do at this point in time? Probably nothing as well. So in an older patient, for example, if they screen for gene, the mutation in age 50 and 60, and they are near the age of their relative getting amyloidosis manifestation, probably I will send them for a PIP scan to rule in or rule out cardiac involvement. So in short, we don't have any guidance for that. I'll try to screen patients with non-radiation modalities like echo or MRI if they are younger. And if they are older, they are near the age of developing manifestation of amyloidosis, then a paraphosphate scan is probably reasonable. Okay. And last question I see here, isn't fibrinogen a type of amyloid? Will antiplatelet be helpful? I don't think so. I think the amyloidosis that we are talking about here specifically would be transthyretin and light chain amyloidosis. Okay, maybe I have time for just one last question. It's my personal question actually. So maybe I direct this to Dr. Xiao. What's your enthusiasm in doing cardioversion, DC cardioversion in patients with amyloidosis, and then you wish for rate control, rhythm control? Will you even entertain that? And what are the things that you look at for chances of success for DC cardioversion?
I think given the deleterious effects of trying to achieve rate control and the loss of atrial systole in these patients, it would be preferable to try and restore sinus rhythm. And one of the most effective ways of achieving sinus rhythm is, of course, to cardiovert them. So I would actually be quite keen to cardiovert them, but with the caveats, as I mentioned earlier on, that you have to make sure that you do a TEE before you cardiovert them. You have to make sure that they are anticoagulated before and after cardioversion. Because, apart from, as I said, the difficulties with rate control, you also have loss of atrial contribution to the cardiac output, right, with atrial fibrillation. So we want to try and restore that, and that would be ideal. And probably just for good measure, after cardioversion, you may want to keep them on amiodarone to try and maintain them in normal rhythm after cardioversion. Yeah.
Okay, thank you. So I think that's all the time we have for today's session. So I would like to thank all our speakers, our panelists for the wonderful lectures that they have delivered. And thanks everyone for spending your Saturday afternoon with us. We have a QR code that we all need to scan to get our points. Please use your phone and scan this QR code and give us your feedback. So there will be a final episode for this series of webinars, and the next session will be covering the management of ATTR-CM, looking at what we currently have and what will be coming to us over the next 4 to 5 years. It's truly a very exciting time for all of us treating amyloidosis. Please scan this QR code again and look out for our poster flyer for the next session on the 30th of November. Thank you, everyone, and have a good Saturday afternoon.